Welcome back to Coast Vue. I really enjoyed that conversation with Adele Lyon. She's such a terrific community leader, and the work the Coast Chamber is doing, and really the work that all the chambers along the coast are doing to serve the business community and sort of be the voice of the business community. Just awesome to see what all they're involved in. Man, they stay busy, that is for sure. Speaking of staying busy, we're going to shift over to my friend Nicholas Conger, Dr. Nicholas Conger, an infectious disease doctor from Memorial, who's been a regular on Coast Vue. We haven't visited in a while, but which is a good thing, actually. That means that's a really good thing. But I've been really looking forward to catching back up with you, Nick, and just first of all, seeing how you're doing, and just to say thank you for what you've done for coastal Mississippi in the last couple of years. It's been no rest in your world for sure.
Well, I appreciate that. And it's great to be back on. So thanks for having me again. And, we just keep rolling along, as things keep changing and we just keep adapting and doing our best to take care of the patient.
Well, we're gonna get the latest, but I've talked in the past on my show about the pretty serious bout of AFib that I had. What made mine unique was that I had what is called a supraventricular response. Dr. Mullins, my local cardiologist, says that actually what that means is that the conductive health of my heart is good. That's one of the signs of good conductive health. I don't have underlying coronary disease or any other issues with my heart. That's sort of the good news. I have an electrical problem that I didn't have, actually. I didn't have any arrhythmias, they call them, heartbeats that shouldn't be like they are, until I had COVID. I had COVID, and then I had 2 Pfizer shots. It's not clear sort of where it came from, but I never had a PAT until after my COVID experience, and you and I've talked about this many times. So then I go off to Destin, and I'm there for a week with my family, and on the Thursday of that week is when I had AFib. It frankly scared me to death, Nick. I sent you a note, and then through friends of ours, as you know, my son's wife is a nurse as well. And we reached out to her. We heard from Dr. Owen, from you, and Dr. Mullen, all of them. I'm trying to decide what did I need to do. They were wanting to convert me in the emergency room, and they said definitely don't do that without a TEE, so you can be assured that there's not any kind of blood clot in your heart. You got to be careful about that, especially since you hadn't had this before. So went into the hospital, into a step down ICU unit, and at midnight, I converted myself. Now, the scary part about it, I was out for a short period of time because my heart actually stopped for like 7 seconds. But then once I awoke and the nurses explained to me what was going on, all the bells and whistles that were going on, it says not terribly unusual for your heart to actually stop for a period of time before it reconverts back over to a normal sinus rhythm. Still doesn't make it unscary, when you look at it on the tape and you see asystole for 7 seconds. But I've had no issues since then. Dr. Mullins has done a great job here locally. I'm on a low dosage of an antiarrhythmic drug, and I'm doing really good. But they say that heart arrhythmias are one of the byproducts of COVID. And again, I didn't have any issues till I had COVID. So hopefully it's something that will resolve itself. That's what I hope for. But, it's just something I'm going to have to deal with. And it's not the first time you've heard this story, is it?
No, certainly not. So a lot of times some of these arrhythmias like atrial fibrillation, there are some chronic changes with stretching of the heart chambers, et cetera, but sometimes it is somewhat out of the blue. There's no doubt that when you make an immune response, you can have focal inflammation anywhere in your body, whether that's from vaccine or national infection. So we do sometimes see cardiac issues after infection or after vaccination. And so certainly something about COVID, we see a lot of people with a known atrial fibrillation come in with an atrial fibrillation exacerbation, and we see that a lot. We've seen a lot of people with new atrial fibrillation as well, and it's kind of interesting, the people who just had the vaccine say, well, I think it's from the vaccine, so I never should have gotten this thing. People that aren't get COVID say, oh, it's from COVID, maybe I should have gotten the vaccine. So it probably has something to do with your immune response to the spike protein, since we see it sometimes after vaccination, sometimes after natural infection. So. Yeah.
So just so people, if you don't know what atrial fibrillation is, when the atrium, which is the top chambers of your heart, are literally in kind of a seizure. The bottom part, your ventricles, are actually trying to pump as normally as they can under those circumstances. The issue, people don't necessarily die from atrial fibrillation, but they do die from really serious conditions that can come if it's not treated. Blood clots are the number one issue. That's you as an infectious disease doctor have to deal with blood clots a lot, don't you, Nick?
Yeah, again, not necessarily an infectious process, but we certainly see it as a sequelae or due to infections. And again, COVID has led to a lot of pulmonary emboli and blood clots. There is something about natural infection for sure that leads to clotting. And again, some of the vaccines were associated with very small percentage, but an increased risk of blood clots following vaccination. So again, something to do with the immune response to this organism that drives that as well. So
it's a crazy disease, man. It's a crazy disease. So if you're talking to people about today, like where we are today, how do you talk about it?
Well, first of all, let's focus on the word today, because I like to throw in this disclaimer or try to remember that, what I say now may be not true 6 months from now, because the virus does mutate, and it seems to mutate pretty dramatically and quickly. Right now, this is a very different COVID than the Delta wave. I mean, completely different. The Delta wave, we talked. It was a really difficult time for us. We had our ICUs were packed. Most of the patients were really sick. Many of them died. A lot of patients on ventilators for weeks or months. Very few got off the ventilators, and now it's almost like a completely different virus. This new strain is very different. Oh, and also with Delta, the ones who were vaccinated did better, clearly, with the ones who weren't vaccinated. With this new strain, it's like 99% of the people we see are on either room air or their baseline oxygen. It really isn't attacking the lungs. And so we are still seeing people come in, but they're usually the elderly, people above 80, elderly, just not eating and drinking. So they're just decompensating. Their medical conditions decompensate because they don't feel well. They might have what we call electrolyte disturbances because they're not getting in enough nutrition, so their potassium and sodium are off. So things like that. But we're not seeing the pulmonary disease at all, not at all. So it's a very different process. We're not seeing young people admitted. Most of more than half of the patients admitted are, oh, hey, they also have COVID, but they're here for something else. It's at high levels in the community. So I like this version much better. This version is much better. It's not sounding the alarm bells with deaths. It's not sounding the alarm bells with ICU admissions, and that's a good thing.
Well, one of the things we're talking to Dr. Nicholas Conger, who's an infectious disease doctor at Memorial and been a regular on this show, been terrific to touch base with throughout this entire pandemic. One of the things, I don't think that media has done a good job, certainly since Delta. I just don't feel like they're confused about how to talk about it. Let's just put it that way. And I actually heard one of them just in the last week or so that said the newest strain is 90% as deadly as the original COVID or whatever. It's almost like they want to send the message that we're in trouble. And we're not in trouble. I mean, the current situation that you're facing is not nearly as deadly as what we have faced in the past, correct?
Correct. It's absolutely nothing like it. It's like a different virus altogether. Again, there are some people who get sick from it, but by and large, this is, remember when COVID first came out, they would say, it's not the common cold. It's worse than it's not the common cold. It's not a flu. It's worse. Well, now it is kind of like a common cold or a moderate flu. Where two people get sick and get hospitalized, but it's pretty rare to get really sick and die from it. Now, again, things can change. This thing can mutate again. But right now, this is a very mild strain.
Okay, so you're an infectious disease doctor, and you spent a lot of time understanding, as part of your profession, understanding the whole issue of how a virus like the coronavirus mutates. And you said from the very beginning that you would expect it to mutate. It might become more easier to catch and less deadly as this thing. That's just sort of the normal route. What has surprised you about this one?
Well, quite frankly, the Delta wave surprised me because that was the opposite direction. That was a more contagious, more deadly, more severe version. And again, usually the natural order is to be less deadly. And that's because if you just think about it, I mean, it's not like the virus is a thinking being, but if the virus wanted to survive, it would want to make people sick enough to cough and sneeze and hack, because that's how it gets spread, right? But not so sick that they curl up in bed and don't move, because then they're not going to go out and spread it to other people. And so the most efficient way for a respiratory virus to transmit is to be mild, severe enough to make you cough and hack, but mild enough that you keep going about your business, so you spread it person to person. And that's generally what things usually evolve towards. And we're fortunately right now seeing it with this virus.
Well, hopefully it's mutated away from the lungs. Hopefully.
Yep.
Hopefully.
That's that.
Yeah, so we're talking with Dr. Nicholas Conger, an infectious disease doctor at Memorial. When we come back, I'm actually curious about what he does when he's not dealing with COVID. What's a day in the life of Nicholas Conger and his team look like? We haven't had a chance to really reflect about that. We'll see you after this break. Welcome back to Coast Vue. I look back on my time at Coast Vue. Started this show a little over 2 years ago. And, the pandemic was kind of getting started. We really didn't know what it was all about. We actually started this show in the studio and had guests coming to the studio. And then I remember I had, on the way to the studio one day, I heard a news report where I really began to understand how you catch COVID. And I realized, wait a minute, I'm sitting right across from someone in the studio. This is probably not smart. We were kind of ignoring the reality. We went ahead and shifted to doing the shows remotely, something we had planned to do from the beginning, incidentally. But there was a time when I wanted to actually work in the studio to learn a little bit more about the radio stuff. And we started doing the show remotely, and we haven't stopped since. And I look back from the very first time that Dr. Nicholas Conger and I started talking, and through today. I mean, he's so practical. He cares about his patients. He represents himself well, his team well, and he's very practical minded, always very practical minded about the whole situation. And that's, I've enjoyed that. You sounded the alarm when you needed to, and you didn't when it was not necessary to do that, when others might be sounding the alarm. You've been a voice of reason, I guess is the way I want to say that. So it's in a lot of ways, man, COVID changed you professionally. I mean, you can't go through what you've gone through and not have been changed dramatically by it. But what does the normal day in the life of Nicholas Conger look like?
Well, first of all, thank you for those kind words. Much appreciated. We've done our best to just try to be, like you said, practical minded. But so infectious disease doctors, we are a little bit unique. We're a subspecialty of internal medicine. So you do internal medicine training first, and then you do 2 to 3 years of extra infectious disease training. And we're kind of unique because we're a mix of inpatient and outpatient. So we have consultations in the hospital we see. So we do hospital rounds, usually first thing in the morning, and then we transition to clinics. So we see people as outpatients. And so we treat infections that other doctors need help treating, severe like orthopedic infections, joint infections, ulcers that aren't healing, and diabetics and wounds and things like that. So infections that require high dose or multiple antibiotics, if they need intravenous antibiotics, we usually manage that and the potential side effects and the lines that go along with it. We manage that for other physicians. And so they send us consultations on things like that. Sometimes consults for fevers that people can't figure out, or we think they have an infection, or and the weird stuff. Do they have a weird infection like a fungus or a parasite or something unusual? And so we do workups like that as well. And then we also take care of chronic viruses like hepatitis B and HIV. We treat hepatitis C. So it's a good variety. I started off in the Air Force, and so I got to do a lot of travel medicine and tropical infectious diseases, and that was a real interesting thing, and that's what attracted me to infectious disease initially. So
yeah, that's so interesting. So what is the makeup of your team? Tell me about what kind of team does it take to do what you do? So you definitely need a team. And so I work with excellent nurse practitioners that definitely help stretch me so that we could see more patients. And I try to see every initial consultation, and then they can carry out the plans. And so I couldn't do what I do with the volume of patients we see without their help. And they're fantastic. And you need a motivated and skilled nurses. Our nursing team, because they're calling the home health companies, they're following up on the patients too. Patients will call with problems and troubleshoot it. We work closely with a lot of the local pharmacies that deliver home intravenous antibiotics, and the home health companies as well that see our patients that are giving them antibiotics at home. So there's a lot that goes into infectious disease. Also, we have to kind of
be open-minded to acute infections. You can't plan an infection. And so if somebody has something urgent that day that needs to be seen, it's frustrating for physicians to say, well, no, I don't have that patient scheduled. But we kind of do need to sometimes drop what we're doing and see that ill patient right there on the spot, because that's when the infection shows up. So we don't often get to choose when we see patients. So we try to be flexible in that regard as well.
Yeah, in some cases, I'm a little bit familiar with this because I have a cousin in Birmingham who has fought over many years. He's had diabetes. He's had some heart issues. And he has neuropathy in his feet, and he lives on a farm, and he still does work on the farm, which is amazing to me. But he can get a sore on the bottom of his foot, and because of the neuropathy, he can't feel it, and it will get bad before he realizes it's bad. And by the time it gets bad, you know how this works. It's almost impossible to heal. I watch him sometimes on one sore on his foot. It may take months, literally months. And he's had to have a couple of toes amputated along the way just because they couldn't solve it. But he'll have to fight this the rest of his life. But by the time they get to you, oftentimes they waited a little too long, and you wait another day. I mean, it could be life-threatening, couldn't it?
Yeah, and definitely with this COVID outbreak, we saw that. So the severity of the wounds when people come in is dramatically higher than it was before COVID. So people, unfortunately, come in sometimes and it's obvious from the first minute you see them and see their wound that they need an amputation, because it's just not going to work. And antibiotics, kind of antibiotic slingers. That's what we do in infectious disease. We try to give you the right amount, not be excessive, but we also have to know the limitations. Antibiotics alone will not heal a wound. It requires wound care. The patient's taking care of their diabetes, taking care of their high blood pressure, their chronic problems. So the antibiotics are one part of their treatment, but you got to treat the whole patient.
I remember one particular patient that you mentioned on the show as an example of why you needed to urge people, don't put off going to the hospital because you're afraid you're going to get COVID, because some of these infections can be really severe, and some people can lose limbs and even die as a result of it. Yeah, I really respected you for how you urge people to take care of themselves. But anyway, Dr. Nicholas Conger, infectious disease doctor from Memorial, it's been a pleasure to catch up with you, my friend.
A pleasure on this end as well. Thank you so much.
Have a great day, and we'll see you tomorrow.